So we'll deal with the site threatening complication by Elizabeth.
Jaya has kind of said the other complications that happen in cataract surgery, and I'll be dealing with posterior capsular rupture, DM detachment, and expulsive hemorrhage. When we drive on the road, we see many signs telling us which way to go and all that. But if we keep ignoring those signs, then we can land up in an accident. So similarly, as you do surgery, it's very important to know where we are going. So PCR is a breach in the continuity of the posterior capsule. Incidence is about 1 to 4%. Now our aim is to analyze how and why a PCR occurs and how we can have a surgical outcome comparable to an uncomplicated surgery. Because a patient comes to you for a cataract surgery to get good vision. So even if you have a PCR or a complication, how best we can manage it so that our surgical outcome is good in terms of visual outcome, early visual rehabilitation, preventive measures of secondary consequences of PCR. And for this, prevention is best. Now, what are the predisposing factors that can cause PCR? Firstly, equipment. Before you start a surgery, make sure you know the microscope settings, your focus is at 0, your IPD, and the patient positioning is very important. Because as you do surgery, if you lose focus, you tend to do a mistake. Second is eyes which have deep set eyes, prominent brow, like narrow palpebral fissure, are difficult cases. And as a initial surgeon, it is best to avoid these kind of eyes. And in case if you have to do also, it's good to do a superior temporal or a temporal incision in a deep set or a prominent brow. And disorder of spine where patient can't lie down, and having a complication in those cases is difficult to manage. Then ocular. The corneal clarity is very important. So cases which have opacity and all these initial stages to avoid so that we have a good view of what we are doing. And too deep and AC, especially in phacos, it makes us difficult with the corneal folds happening, deep AC, trenching, assessment of depth and all. And undilating pupil pseudo-exfoliation cases are predisposing factors. The other is the surgeons. Learning curve. Each surgeon has a learning curve, and it's important that from every case, like if you're starting from first year, we keep telling you at least every step you should have pushed forward so that by at a particular time you are good with the surgery and you continue doing the same steps till you are thorough with the whole surgery, instead of seeing videos or trying out new techniques which are done by people with very experienced hands. Second is we should be able to recognize complications when it occurs. So observing cases, observing as seniors do to recognize how they manage or how a PCR looks, and is very important. The other is avoiding zone and going to the periphery where it's unseen, and manipulations, aggressive manipulation should be avoided. And a phaco surge, which I talked about. Now, mechanism of PCR, wound construction. Can somebody tell what causes PCR? Like, I think Jaya just gave it. So, in ECC, usually a small section and trying to forcefully deliver through a small section. And SICS also, like as she said, superior rectus is very important. The other thing is assessment of the cataract is very important. Superior SICS, if you make a stone and you have a large nucleus and we try to prolapse it with a poor rectus, then invariably we'll land up with a superior end. So assessing the type of cataract and the force that's used to deliver the nucleus. In phaco, leaky wound with either section or side port, unstable AC, anterior chamber depth, This can predispose to a PCR. Now next, coming to capsular excess or capsulotomy. So in ECC, we do capsulotomy. So if your capsulotomy is not complete and you have capsular tags, then during cortical wash or while you're doing nucleus delivery, is every chance of you pulling on the cortex and it tearing and causing a PCR. Next is in SICS. SICS blue methyl, like Jaya said, it's very important to have a larger rexus so that with the fluidics and you're prolapsing the nucleus, you do not cause damage to the rexus margin. And make sure your rexus is complete. There is no tag at the side port or anything, but your rexus is complete and large enough. And in phaco, it's important to have a intact capsule, good rexus, adequate size, and without any extension. Even if there is a small extension, we can do the phaco away from that extension. But again, it is in experienced hands. If there's extension, it's better we convert to SICS or ECC. So phaco, the intact capsular rexus is very important. Similarly, cases of hypermature cataract, we should expect a fragile capsule. There will be fibrosis, and in intumescent cataract, it will be dome shaped. So you have to flatten the capsule. Otherwise, when we try doing a capsular rexus, the rexus capsulotomy can extend and cause a PCR. Now, in hydrodissection, during hydrodissection, PCR can occur. So the mechanism is when there is a small rexus or a larger nucleus, there is a block to the outflow. And because of this, the only place the PC can open is downwards. So you have a PCR. And other thing is, in a main wound is sealed and you hydro forcefully through the side port, this can also cause a PCR. So that is why in phacos, we do the hydrodissection through the main wound instead of through the side port, which is a safer procedure to do. And too much fluid or too forceful injection. It should just, in blue methyl, it should just be jets of fluid and not continuous full forced fluid. The other is there is inherent weakness of the zonule, like in PPC, hypermature cataract, vitrectomy eyes where you expect a PCR, and pseudoexfoliation, high myopes where the PC is thin, and in traumatic cataract. The other thing is tip of the cannula. Sometimes we go under the rexus margin, just keep going in without knowing where the tip, we can injure the PC, directly injure the PC and cause a PCR. And if PCR is not recognized at this stage, then when we raise a phaco probe or the next step of where we are going to do a nucleus delivery, there's every chance of a nucleus shock. So what are the signs of PCR? Can somebody say during hydrodissection, how can you suspect that there could be a PCR?
A pupillary snap that we have.
Yeah.
There is.
What is pupillary snap saying?
So in a fully dilated pupil, if the PCR occurs during the hydrodissection, the pupil becomes small at once and the anterior chamber depth also decreases.
Shallows and pupil dilates again. So that is pupillary snap sign. What are the other signs? Okay, there can be sudden
then peaking of pupil.
Chamber. There can be abnormal, yeah, peaking of pupil, sudden deepening of the chamber, abnormal tilt of nucleus. If it's a larger end, the nucleus tilts so much, and snap sign. Okay, so this can happen during hydrodissection. So if you see any of that happen, we will see later how to deal with this. So you should first recognize that there is something wrong and stop the procedure and reassess the eye. Okay. So next is nucleus delivery. During nucleus delivery, Jaya said difficulty in nucleus delivery because of. Then in SICS, what all?
Ma'am,
What are the
inadequate
signs?
keratome
Just now
entry.
JGN said. Yeah, inadequate keratome. Your section is small. Then rectus is not good. But what do you see? You're trying to prolapse the nucleus and you find that the rotation is difficult. So you should ask whether you ask or if there is a bit in the chamber. That is why rotation is difficult. The second thing is tilting of nucleus. Suddenly the nucleus can tilt. You might see clearing of the cortex, or you can even have difficulty in delivery. If you have difficulty in delivery, your section is clear, or if there is any width in the section. And if you see clearing of the cortex, a red reflex seen, then again presume that there is a PCR. So for all these signs, you stop the surgery and assess whether this has happened and if there is a PCR. In fact, like she said, trenching. So soft cataract, if you use very high power or is a better option. So soft cataract need to be handled when you are a little more experienced. Less power and more mechanical force. Like they say, hard cataract open, and so you really need to trench well or do a stop and chop with minimal mechanical force on the lens so that the zonules of PCR is not compromised. And depth assessment. You should make a good cross range depth, not the center, and movement. This is very important. So you go from the center down and come up like a boat shaped. So sometimes we have seen as you trench, you tend, when you're going to the periphery, your foot pedal goes full down. It shouldn't be like that. So with that speed, if you're going beyond when you leave the nucleus level, then you are in the epinucleus and cortex. So the probe can cause a rent. And other is movement. It should not be very fast movement, slow. So in cracking, then inadequate trench. If your trench is not adequate, it is dense in the center. When you try to crack, there is difficulty in cracking. And the other things we see is the way you use your instrument, the dialer and the spatula. It should be in the floor of the trench and equal force on either side. You should not cross your instruments. And in leathery cataract, like in diabetic cataracts, the assessment of the cataract is important. So if you are doing on a diabetic cataract, you should know that it's leathery and it's hard, and difficulty, good trenching is necessary. Then the instrument direction. Like I said, it should be in the floor of the trench, and you just need to rotate your instrument. You don't have to mechanically push the pieces apart. So surge. What is surge? Secondary DNP. Nobody's answering.
Don't know, ma'am.
Somebody.
Surge when you during phaco, ma'am. Yes, ma'am.
Ma'am,
I think none
when
of
the obstruction
this
is
batch they have started.
hello, ma'am. When the obstruction is suddenly released
Yeah, correct.
at the phaco
Go
tip,
on.
there is the sudden withdrawal of the fluid that causing the collapse of the AC.
Okay, when the occlusion breaks, there is a sudden withdrawal of fluid from the AC and the AC collapses. So that is caused. No, it is occluded by a piece. Okay, so once that piece is even, fluid from the bottle infiltrates stent. So if there are any other reasons, what happens, the AC suddenly collapses because fluid is coming out the vein. It's called surge. So with machines, high-end machines, the surge is controlled. Otherwise, the only way is to check your aspiration rate. So you can, if you feel there is too much surge, you lower your aspiration rate. You can increase your bottle height. The other thing is you should check your wound, whether it's a leaky wound. If it's leaky, then put a suture. Sometimes because of your phaco itself, you can cause corneal burn and the wound can leak. And best is to maintain phacoing in the safe central zone. And towards the last piece, sometimes we see rents happening more when you are taking out the last piece. So that time, if you think there is too much fluctuation, you can use viscoelastic and have a very good foot control. So we surgeons ourselves could be a reason for the surge happening. So we have to check all this and correct ourselves, because during surge there is every chance of a PCR.
Come in between. So it's very important to understand
Yes,
what surge is. Surge is when your outflow is more than your inflow. So you either reduce your outflow or you increase your inflow. You have to see what is causing it. So based on that, you decide whether you want to increase your inflow or you want to decrease. So aspiration is nothing but decreasing. Like Dr. Elizabeth said, you reduce your aspiration, means you're reducing your outflow. So you need to understand this basic thing. It's just that when you see surge, you just don't continue. You decide, why is it? Is it because of a leaky wound? Is my outflow more? Should I reduce my outflow? Or is your bottle may be, your ringer lactate or TSS bottle may have been over. That's why the AC is collapsing. So you need to check all around and then decide what you want to do next.
Thank you, sir. So next is during IA. So first thing is visualize well. If pupil is not very well dilated, you can use adrenaline to dilate it and maintain the anterior chamber depth, especially in ECC when you're doing cortex wash. Pardon?
Just a word, Elizabeth. Regarding surge, just to add, the surge is basically the mismatch between the irrigation and aspiration. So, like whenever there is an increased aspiration and decreased irrigation, there can be a surge. It can be a small piece blocking the tubing of the outflow or excess leak. So the amount of fluid to be aspirated becomes less, so there will be a surge. So whenever the surge happens, either you decrease the foot pedal speed, so the aspiration becomes less, or increase the bottle height, or decrease the flow rate. So that is the basic concept of surge. Yeah, thank you.
Thank you, sir. Thank you. So again, in ACC, make sure you suture. If with just 2-stage sutures, you think the AC is still shallow, you can put 2 more sutures and then do your cortical wash. Always visualize and go in clock hours. One thing is the Simcoe cannula. We should understand that it's a curved instrument. So the direction should be towards the cortex, the tip towards the cortex. And otherwise, if the patient is straining or anything, the curved part of the Simcoe cannula can touch the PC and it can cause a PCR. And single port also. Similarly, direction of the port. The port opening faces you, don't turn the port towards the PC because it can get hold of the PC. Again, in phaco, the aspiration and irrigation rate has to be correct. If you do a fast aspiration, the AC can shallow and PC can come up and you can get hold of the PC. And the other thing is, if in phaco, as you're doing or any surgery, just if you think the AC shallowing, just look at the bottle. Sometimes sisters might miss it, and always check the saline in the bottle. So this is actually, I just wanted to show you, if you hold the PC. So this is actually a pars plana illuminated view, but you can see the folds. these folds. So during visco wash or cortical wash, if by chance you get hold of the PC like that, just come to irrigation and don't aspirate. So then like that you will not damage the PC. In IOL insertion, like Jaya said, visualize the PC, the capsule. If pupil is small, just push back and see if it is fine, and then insert the IOL and put visco in the bag, in the AC, form the AC well and the bag. And if there are any capsular tags or tear, while dialing, you can tear the capsule and cause a PCR. The second other thing is dialing. So dialing technique should be correct. It should be downwards and into the bag. And the before doing that, always make sure PC is there by the reflex. Sometimes if there's a large PCR and an intact bit face, we can miss out on the PC and it can lead to a IOL drop. So always put the leading haptic in and slowly put the trailing haptic. So if you see while you're putting the leading haptic in and as you're dialing the trailing haptic, if you see a tilt or it is not stable, just don't leave the trailing haptic. With another instrument, hold on to it, assess, and then only put the trailing haptic in so that you can avoid a IOL drop. Even by chance, if you think the IOL is dropping and you're calling one of us, make sure you, with another instrument through the side put, you, with the spatula or a dialer, you hold on to your McPherson's, hold on to the IOL. So that's with IOL insertion. And in ECC, it's better to put with your McPherson's than dialing it in a ECC wound. So that's why we have told first years to avoid dialing the IOL. In SICS and phaco, you can dial the lens and make sure both the haptics are in the back, and or if you're placing in the sulcus, both the haptics are in the sulcus. Now, steps of management of PCR. Now, you have recognized that there's a PCR, you know how to see that there's a PCR at each stage we saw. Now, it is to how to manage once a PCR occurs. So, first thing is to identify at what stage it occurred. Is it during nucleus delivery, cortical wash, or IOL insertion? And whether there is a vitreous loss or no vitreous loss. Second thing is avoid enlarging the rent. So suppose you're doing a delivery, you think there is a bit or cortex aspiration, you held the PC or you're pulling on the PC, just stop the cause of the problem, whatever it is. So stop, avoid aspiration, and if you're doing phaco and there's a rent, don't immediately come to zero and come out of the eye. You come to as irrigation, come to foot pedal 1 and remove your second instrument, put in some visco so that the AC is formed, and then only come out with your probe. Now regain control. The first thing is be calm. Don't try to blame either your sisters or others or shout, but try to be calm. If you're repeatedly doing, then we need to learn what stage we are doing the mistake. Second is accept. Don't try to ignore, because it is the patient's eye and we are trying to give him a good vision. So if there's a PCR, don't try to accept that a PCR has occurred. Third is assess and visualize. What is the margin? Is it a small rent, large rent? Is there width? So ask and visualize the eye and ask for opinion or help. Like immediately call out for help. But if you're alone, then we'll see how to manage it. Next, refocus your mind and the microscope, because our mind is out of focus and we are unable to see. So make sure you are focusing, suppose on the PC and not focusing on the cornea. That happens many times. So when you're doing cortical wash and all that, we keep telling you focus on the structure on which you are operating. And the other thing is focus on the patient, whether the patient is straining, there is positive pressure. So whether he has to void or patient has some difficulty, so, or it's a tight speculum. So assess what is the cause for the positive pressure, because positive pressure itself can cause PCR. The fourth is confirm PCR. So make sure there is wit loss or no wit disturbance. So you check the section, the side port for wit with a flattened cotton applicator or a wit. Never drag the vitreous. Just gently swipe the section from one end to another end. And if you see a wit strand with a Vanner scissors, just cut it. Don't try to pull the vitreous. And if you have put a superior rectus, you remove the superior rectus, the clamp. And if there is no wit in the section, then with a spatula, you can check if there is wit in the AC, you can assess the PCR, rule out if there is a zonular dehiscence, and depending on the stage, you'll manage. So this is a video. You can see here how to assess through the side port with a spatula if there is a wit. Can you visualize the small rent in the center? So you go through the side port with the spatula, and along the margin, you just swipe to the center of the pupil. Avoid going to the periphery, because when you go to the periphery, you can touch the iris and it can cause iris bleed. And it worsens the condition. And you just need to check the margin, because the vitreous comes through the rent, through the margin to the section. So I'll just play this again and swipe. And as you swipe, can you see the movement of the PCR margin? So there is a AC that you visualize. Once you have section of the vitreous, then you go through the side port of your ECC, suture the wound, and through the side, swipe and the vitreous, any strand or wit, to the center of the eye.
Elizabeth, 1 minute.
Now, vitreous
one more
prolapse.
thing that you can do is you can inject triamcinolone. Whenever you suspect you're not sure whether there's vitreous, you can come out. You can dilute triamcinolone and inject it into the vitreous, into the anterior chamber. The vitreous will stain. So that's another way that you can identify vitreous in the anterior chamber. Yeah, thank you.
And before putting this spatula, just check the section once. Always clear the section of the vitreous and the side ports, and then proceed, put the spatula inside and go the sweeping. Because if you sweep directly, it will cause extension of your rent margin. So always clear the section and the side ports of vitreous, and then proceed with the sweeping to check the vitreous to the center. Yeah.
Okay. So suppose there's a vitreous prolapse during nucleus delivery. So if it's an ECC, check the section, extend the section, and with the vectors you can remove the nucleus. And in SICS also, again, extend the section with your scissors on either side, and then you can put visco to gently elevate the nucleus, and then do with the vectors or with a so the main point here is not to apply force into the eye trying to deliver the nucleus. And if since there is already a PCI, it should not enlarge, and there should not be a nucleus or a drop. So in phaco, again, visualize to the rent, extend. Again, you can convert to ECC, just extend and remove if it's the whole nucleus. The rent has occurred when the nucleus is in the eye. Or you can use visco to elevate the piece, and with the probe, if it's a large piece, with the probe, you can just hold the nucleus and then deliver it. Or you can use a chopstick technique with two instruments, with the visco just above the PC so that the PC is blocked, and then remove the nuclear piece. In all this, make sure the AC is formed and the section is adequate to remove the phaco piece. Would Vivian ma'am or VTS just want to say anything in phaco nucleus?
No, don't understand. What was your question?
No, ma'am, nucleus removal. Anything you want to add, ma'am?
Nucleus
During
removal.
nucleus removal, if there's a
Nucleus removal
vitreous.
during phaco.
Yes.
No, if it all depends on which stage of nucleus, whether first quadrant, second quadrant, or in which part you notice the rent. If it is in the initial stage itself, if it's going to be a phaco, then better to extend the section, clear the vitreous from the section and the side port, and probably deliver the nucleus with the vectors or under visco cover. And especially you have to convert the rexus into canopina and then prolapse or gently remove with the vectors. Because with the rexus, if you try to remove the nucleus, it's going to come with the bag. So we want to save the bag and the rexus. So if it's going to be rexus, if you're able to prolapse, well and good. Otherwise, if it's a whole piece, then it's better to put a vectors under visco and then take out the nucleus. If it's going to be one or two pieces, definitely you can see the rent margin. So you'll be able to clear the vitreous nicely from the section and under the nucleus. Nicely keep the nucleus buffered with the high density viscoelastic or OVD under the nucleus and keep it away from the rent margin. And you can eat it away with the phaco probe with the less vacuum and less aspiration. And then otherwise you can even deliver with visco cover. If you have already extended the section, you can deliver it under a visco. And there is sheet slide method which has been described, and there is an IVOL, which a piggyback technique which has been described. If you are expert in that, definitely you can try that also.
Thank you, ma'am. So, suppose during nucleus delivery, a nucleus drop occurs. You're trying to deliver or rotate the nucleus, but you see that it's tilting and going in. Avoid chasing the nucleus if it's gone to the midvitreous or anything, because you can cause more damage, and it's better to refer to the VIA surgeon. We can do vitrectomy, so do a anterior vitrectomy. If the piece comes up, then you can take it. Otherwise, avoid chasing the nucleus piece or a nucleus drop, and close the eye, and it's safer to refer to a VIA surgeon. So in this, you can see the here there's a PCR. This is the margin of the PCR through which vitrectomy is done. Now, if you take vitrectomy, anterior vitrectomy, it can be limber. That is what we do, anterior surgeons. By vitrectomy and anterior vitrectomy with an the anterior chamber, you avoid vitreous infiltration and wound, and capsule, and to avoid secondary complications like corneal decompensation, glaucoma. Now, automated anterior vitrectomy, bimanual or coaxial. Bimanual means the irrigation is different, separate from the cutting, and in coaxial, it is in the same probe. So suppose there's a PCR occur, by the time you suture or assist, ask the assistants to get the machines ready, then close the wound with the suture, and before that swipe the wound, the side ports for any wit, and cut it with vanners, and swipe the AC like how we showed with the spatula for any wit, bring it to the center of the eye. And this is the vitrectomy probe that we use, and the cutter, it is a guillotine cutter. So if you need to extend the side port a little, because you use a 23 gauge cutter or a 20 gauge cutter, you need to extend the side port a little for the probe to go in. So extend the side port, close the wound, and first go in with the cutter. In the hand, you use the irrigation. So keep the irrigation at very low. Bring the bottle height low. Initially drop, and then in the machine, in the phaco machine, you choose the vitrectomy for the machine, and then you keep the cut rate high. You can keep it at 800 or 1000, or in Centurion and all, it is like 3000, 5000, and keep the vacuum low, aspiration low, around 130 and all. So cut rate has to be high. Then the option is there in the machine, that is cut IA, or that is used for vitrectomy, and IA cut for cortex. Cut IA means it cuts and then it aspirates. So when you're doing vitrectomy, you choose that cut IA. And if you're removing the cortex or piece, then you choose IA cut. So it aspirates and then cuts. And before you start vitrectomy, once the sister is connected in a bowl of saline, you put the probe and press your foot pedal and see if the gelatin, that blade is moving. So this is a diagram. So you go with the irrigation cannula and with the vitrector. Suppose there's a rent here, you go into the rent and do the vitrectomy, and then you come to the anterior chamber and clear the vitreous from the anterior chamber. So that if you keep on cutting the vitreous, you can keep putting the vitreous, and never drag the vitreous or move your vitrectomy too much, because it can cause traction on the vitreous. And for that, we should know something about the vitreous, that it is 98% water, but it contains of collagen bundles suspended in coils of mucopolysaccharide, and it's a gel-like thing. So mild traction, the gel can absorb, but if there is too much traction, this traction is transferred through the collagen bundles to the retina, resulting in tears, and can cause retinal detachment. So we have to be careful moving our probe inside the eye. And this is the foot pedal, like I said, for cut IA and IA cut. So this is irrigation, vitrectomy, and then aspiration, which is used for vitrectomy. So your foot pedal in position 1 is irrigation. Then when you go down, it's in vitrectomy, and then in 3 it is aspiration. And the other way around for...
That's a fantastic slide which you have. That's a very important slide where you're showing the vitrector going through the PCR. So what you need here is a high cutting rate, low aspiration rate. You need to have your vitrectomy probe facing downwards, because what you want is, so that the vitreous cuts and falls back. You don't want to turn your vitreous probe upward and cause the vitreous to keep churning and cause a tag on it. So you hold the vitrectomy probe downwards, so that with a high cutting rate, low aspiration rate, you should have viscoelastic around in your posterior capsule. Once that is done, once the vitreous cuts, it will fall back. The other vitreous which is there in your bag in the anterior chamber can then be eaten away with the vitrectomy. Yeah, removed with the vitrectomy probe. That's a very nice slide.
Thank you, sir. So that's it. So exercise, press the foot pedal and vitreous probe into the PCR, and then when you come to the AC, the probe facing you, and clear the AC of the vitreous. And as you do vitrectomy, the anterior chamber is vitreous is removed, so you have to slowly increase your irrigation if the AC is collapsing. And another thing is, the irrigation cannula should be away from your PCR. If it is towards the PCR, it can hydrate the vitreous and more vitreous can prolapse. So make sure the irrigation cannula is away from the PCR. And in ECC, if you sometimes the eye becomes so soft, you can gently clamp your superior rectus, because the eye is in a hypotonous eye, the vitreous can come from, more vitreous can prolapse. So make sure you increase the irrigation as you keep doing the vitrectomy. Then again stop, come out, check with the spatula if there's any vitreous strand or any vitreous in the AC. The other thing we have to look is the PCR margin. So so like sir said, we can use triamcinolone if for staining the vitreous, we can visualize the vitreous better. this is a, you see here, there's a PCR margin. So once you do vitrectomy, your margin should be clear. There should not be any peaking of the margin, and it should be blended. If the PCR margin is peaking, then you know there must be a width strand, or it could be a cortex strand. So make sure that once your vitrectomy is done, the margin, PCR margin is blunt, round, and there is no peaking or peaking of the pupil also. So that's how you know that the vitrectomy is complete. There is no vitreous in the AC. The PCR margin is defined. There is no peaking of the pupil, and there is no vitreous in the side ports or in the section. Now, cortex aspiration. So you can either do a dry aspiration with a Simcoe or a single port. For this, you can infuse Visco into the anterior chamber, and then without any irrigation with the Simcoe cannula, you remove the cortex. Just hold the cortex and remove it. And in phaco, you can use the bimanual with the flow away from the rent with a low irrigation, bottle height low. And if during cortex aspiration you find that it is difficult, you reassess. Sometimes there might be vitreous, or it could be a zonular dehiscence. So as you're removing the cortex, you see that the bag is moving, or cortex is not coming, stop, come out, again swipe and see if there is any vitreous in the section or in the AC. And avoid AC fluctuation. You would have done a good vitrectomy, but during then it can cause enlargement of the rent. Other thing is, if you see fluffy cortex, you can put Visco under it, and with the cutter itself you can take. So to avoid, sometimes the epinucleus or the cortex can go into the vit cavity. So you would have removed the nucleus, but if there is a chunk of epinucleus, then with the cutter itself you can remove the epinucleus sheet to avoid it from going into the vit cavity. The other thing is, remove the cortex away from the rent. Suppose you have a superior rent, remove the cortex inferiorly everywhere, and then come to the superior part. Next, assess the capsular support. So you have done a cortical wash, and then you see if it's a small rent, central rent, there is no bit disturbance and all, you can put IOL in the back.
One more thing, Elizabeth, sorry.
Yeah.
When you are doing cortical aspiration, either with the Simcoe or the single port, always go towards the direction of the PCR. I mean, suppose if you have a PCR from 6 to 8 o'clock, then you have to go in the direction. So either you go towards 6 o'clock or towards 8 o'clock. If you go away from the PCR, again, you may extend the rent. So in the direction that clockwise or anti-clockwise, whatever you are following, you have to go towards the PCR rather than going away from the rent. So in that way, you can prevent the extension.
Okay. And thanks, Jivi. Small rent with vitrectomy done, capsule bag is intact, you can put IOL in the bag. If it's a larger rent and okay, it is like slightly extended beyond, then better to put a IOL in the sulcus. And in phaco, if you're putting, it's better to put a 3-piece IOL in the sulcus. And always the haptics should be away from the rent. Like Jaya showed, the haptics should not be in the direction of the rent. Especially if there's an inferior PCR, if the haptic is inferior, it can dislocate into the vit cavity. So the haptics have to be away from the rent. And in cases where there is no capsular support, the options we have is a AC IOL, a sulcus IOL, or leave aphakia. We sometimes leave it aphakia when you have like corneal edema, you can't visualize the margin, you're not sure if the capsule is intact. Always it's better to be in favor of the patient so that we can reassess the patient and later on plan for a secondary IOL than giving the patient a poorer choice. Suppose later on we find that the rent was okay and the bag was good, we could have placed a PCIOL. So in cases where you can't visualize or there is bleeding, it's better to leave it aphakic. And iris claw lens is the other choice, but the outcome is not so good. So sulcus IOL, if there's a VR surgeon in the OT, you can do it as a primary procedure. Otherwise, you can wait and do it as a secondary procedure. And always do a peripheral iridectomy, which can be done with the vitrectomy probe itself. So you put visco, you constrict the pupil, and then you go with the probe facing down and cut. And as you see the pupil margin move, you know the PI is complete. So that's how you do the PI with the vitrectomy probe. So do a PI to avoid any pupillary block glaucoma later. So this is a case with a, you can see there's a large PCR, but a very well placed IOL. In this case, if you see, you can see the PCR margin and inferiorly. The IOL has decentered inferiorly, and this can cause a IOL dislocation. So after doing this, you close the wound, remove the visco, recheck again for vitreous strands in the side ports, and AC to be well formed. It should be a well formed tight eye at the end of the surgery. And your criteria is at the end of surgery, the pupil should be round, the IOL should be stable, well centered. It shouldn't have decentered. If it's decentered, reassess again, and a well formed AC. Then you know you've done a good vitrectomy and a IOL is placed properly. And other thing is, if the surgery is too long, or if we are doing more vitrectomy in the AC, sometimes we can land up with corneal edema. So this is a learning curve, but slowly we should get over that.
And one more thing, just please suture the section, because post vitrectomy, the scleral rigidity is too low. We cannot never assess. Better to take a suture, either it is phaco or SICS. Okay. And can we go a little faster? It is 7:45. Yes, I don't want to rush you. Sorry.
No, I'll just finish. Just a word on anterior vitrectomy pars plana approach, which is done by some surgeons. Anterior surgeons can do in this. The idea is to pull down or bring home the vitreous. So what happens through the AC port or side port, you put the infusion cannula, and through the pars plana, around 3.5 mm from the limbus, you make an incision, and with a 23 or 25 gauge vitrectomy through the pars plana, that you should use your dominant hand. So you go in like this. So there's a PCR, so you go under it and you cut the vitreous. So what happens? You're pulling back the vitreous from behind the PC, and then once this is done, then you can come through the anterior chamber and clear the vitreous that is in the AC. So this is the pars plana approach. And the advantage is hypertony is avoided, less vitreous prolapse, and even if a small nuclear bit residual lens matter or epinucleus is gone, that can be removed with this. So that's with PCR. So some take-home tip is prevent it. So for that, pre-op assessment, intra-op assessment, and continuous observing to learn about PCR and how to manage is important. So recognize, don't panic, don't deny, visualize, don't complicate, denying and trying to manipulate and worsen the condition, but early recognition and early management gives a better visual outcome. And do a good vitrectomy and IOL placement. And ask if unable to manage or assess. And explain to the patient the next day if there's any complication, tell the patient, and make sure you follow up the patient so that if there's any secondary consequences, that we can avoid it or treat it. So that's with PCR. Deemed detachment. Share. Then the next, just this Descemet's membrane detachment, I'll just rush through it. So, can anybody say the risk factors for Descemet membrane detachment? Hello? Okay. Descemet's membrane. So, Descemet's membrane detachment, one of the risk factors is old age, where your corneal endothelial count is compromised, or there's a corneal endothelial dystrophy, or pseudoexfoliatic eyes, glaucomatous eyes. These are prone for Descemet's membrane detachment. But most of it sometimes happens due to the surgeon's hand. So, one of the reason is the cannula tip. So, especially the cystitome, when you're making a side port and trying, either your cystitome tip is long, or the direction you go, going it tilted, you go directly pushing the tip, it can cause a DM detachment, small DM tear. And as you continue doing it, and or you inflate it with the cannula tip fluid injection, that can worsen the small tear and cause a DM detachment. Other thing is intralamellar hydrodissection of cornea, which creates a space between the stroma and the decimets. The other factor is in shallow AC. And the AC is shallow, trying to go in with instruments, you can cause DM stripping. So always make sure AC is well formed when you go in with instruments, because the instrument itself can cause a DM tear. Other thing is viscose operation. This has happened in ECC. You made a lamellar entry and then you inject visco, and you don't realize that you are injecting into the between the space between the stroma and the decimets, and not into the anterior chamber. So this can cause a near total DM detachment. So when you go with the visco cannula, make sure the cannula is in the AC and you're pushing visco into the AC and not into the DM. And in phaco probe, the main incision, each time you go in with the probe and keep coming out, the probe itself can push the DM and cause a DM detachment. So this is a, I don't know if you can visualize this. So here you can see the instrument goes and there's a small DM stripping. And as you keep going in, this is the probe, the DM starts getting lifted up. So you're worsening the small DM tear that was there. This is again with the probe. As you go the probe, there's a small detachment. Again with the fluidics and the probe, the detachment is larger. So on the table, if you see a clouding or folds in the cornea, make sure, reassess whether there is a DM tear, is there a membrane fluttering. Sometimes you can mistake it for an anterior capsule. So before you try to remove it, put saline, remove the visco and see if it is a DM. So in this case, you can see here the detached DM. Sorry about the pictures. So management. This is by first thing is careful instrumentation, direction of your instrument, making sure the AC is well formed, and if there is a small decimate stripping in the one side port, avoid going through that side port and use the other side port. Or in ECC, avoid going through the same. The other factor we have seen causing is repeated iris prolapse, and you're trying to deposit the iris. This itself can cause a mechanical DM detachment. So if it's a small decimate stripping, you can just avoid that port, visualize, and do a good visco wash. Sometimes because of the visco separation, you can miss a DM. So make sure the visco is washed very well from the AC, and then see if it is self-repositing. Sometimes inferiorly and all near the ACM, sometimes with just as you hydrate the wound, it will self-reposit. Suppose it is not repositing, there is a DM detachment, small one. They say like 20% of the cornea, that could be a detachment. The other factor is they have used this HELP algorithm, that is height, extent, length, pupil for DM detachment assessment. But this is usually a ASOCT, like you see it next day and then decide. But on the table, we have to visualize and see if there's a DM tear. So if there is a small tear and it is not repositing with your hydro, then put a air bubble. The other thing is, if the DM detachment occurs before your nucleus delivery, then you have to take a suture, Detachment of Pcr suture. So make sure you take a full thickness deep suture to the sclera, reposit the decimates, and then only manage your nucleus. Otherwise, during nucleus delivery, the DM can strip and come off. You can have a decimates loss. And make sure your wound is tight after the putting the air bubble. If there's a large decimates detachment, then you'll need a full thickness corneal suturing, or you can put intracameral air injection, or if it is available, best is to use an intracameral C3F8 injection. So this can be a primary or a secondary option. So details I'm not going. So if there's a large detachment, then you remove the visco, see if it reposits. You can use an end eliminator to check the DM, and then make a side port. Suppose there's a superior DM, make an inferior side port and take C3F8 in a syringe, and it's an expandable, it's like 15% expandable. So you take it and then inflate at least 3/4 of the end. Make sure the wound is tight before you inject. So suture the wound, hydrate the other side port, and only through this one, just inject the C3F8 and with a butt, immediately close it. And make sure it is very well formed, 3/4 of it, and do a PI to prevent pupillary block. So this is a picture of a patient with DM detachment, and this is, they put the C3F8. So that's just an outline of DM detachment for want of time. So I'll just go through the expulsive hemorrhage, which is a nightmare for any surgeon, and which we really don't want to see. So expulsive hemorrhage is suprachoridal hemorrhage, and it's a rare, potentially devastating complication. And this occurs because of accumulation of blood within the potential space between the choroid and the sclera. It's less common now because of small incisions, self-sealing wound, and modern techniques. So when an expulsive suprachoridal hemorrhage occurs, it can be either self-limiting, it can be occurring towards the end of your surgery that you miss it out. So it could be self-limiting, or it could be localized hemorrhage, or it is so bad that it leads to expulsion of the intraocular contents. So it's very important to recognize early and manage immediately. So risk factors are advanced age, where like atherosclerosis of the arteries, hypertensive, cardiovascular conditions, patients on anticoagulants and antiplatelets, an ocular condition like high myope, glaucomatous patients, nanophthalmos eye where the choroid is thick, post PK, large incisions. So that's why I said like SICS phacos, the chance of expulsive is lesser compared to ECC, where you make a larger incision. So the pathophysiology is basically when there is an increased blood pressure and there is a sudden low IOP, there is sudden decompression. So sometimes it happens when you suddenly open the wound or you deliver the nucleus. So that's why when you make a side port, you make a controlled entry. Your section also has to be controlled so that you avoid, in high risk cases, sudden lowering of IOP, which can lead to a suprachoridal hemorrhage. And there is increase in transmural pressure in the choroidal plexus and hemorrhage into the suprachoridal space from the long and short ciliary arteries. So what are the signs? How will you know that expulsive is occurring? So as you're operating, you see suddenly the anterior chamber is shallowing, there is increased IOP, the eye becomes firm, see if the patient is straining, then there is iris is prolapsing if you have opened the section, or there could be a loss of the red reflex. You see a dark reflex. Patient complains of severe pain, and without any manipulation, we can see the nucleus, vitreous, or the ocular contents coming out. You're not using an instrument, but spontaneous extrusion happens. So this is a case where you can see there is a red reflex, and slowly the reflex is changing, and it has become like brown black color. So this is a case of suprachoridal hemorrhage. So if you see anything like this, immediately close the wound. The first thing is close the wound. So to close the wound, you have to use 8-0 suture sometimes, because the pressure is so much, and you can control the IOP. You can give IV mannitol and assess the patient again. And preventive measure is, if you give a retrobulbar or peribulbar anesthesia, make sure you do a good massage. IOP is controlled. Especially we see suprachoridal hemorrhages happening in glaucomatous surgeries. And the other is pre-place suture. So if you expect, it is good to place suture before your nucleus delivery. So that is called pre-place suture, without tying the sutures. So that is the intra-op management. So recognize, close the wound immediately, and reduce the IOP. Reassess. If you want, you can use indirect to see the pit cavity, and then manage the patient later. The other thing is, previously they used to do posterior draining sclerotomy, but now it is done as a secondary surgical procedure after assessing the patient the next day. Whether it's a small hemorrhage, localized, we give steroids and assess the patient, and then decide on surgical intervention. Thank you.
It's a very good class. Yeah, thank you. Thank you. Thanks to you, Elizabeth and Jaya. Any questions from the students?
Intra-op complication itself is a very big topic. Each complication is a big topic. So we tried to cover as much as possible. It's taken 2 hours.
And the other thing is, videos and all we couldn't show, but
so you have to imagine.
Yeah.
So is it any questions? Good night then. Everybody's want to have their dinner and sleep, I think.
Yeah, it's very late now.
Long class.
Yeah.
Hypoglycemic
class, but very long. Yeah, very long. I think we can have this over 2 sessions and just take 1 or 2 topics like a PCR or a zonular dialysis next time separately, rather than this whole thing. Very nice, but very well done. And you'll have to tell us how to do those drawings, okay?
Okay, sir.
Thank you, sir, for your inputs also.
Thank you. Yeah, thanks.
Thanks a lot. Thanks a lot. Thanks a lot, Elizabeth.
Okay, thank you, everyone.